Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello and welcome to the latest video podcast for the Medicine Journal. I'm Albert Ferro. I'm the chair of the editorial board of Medicine, and I'm very pleased to be joined today by Drs Tristan Barber and Karen Rogstad. So welcome to both of you.
Thank you.
Nice to see you both. Now, the reason we're meeting is because the latest two issues of Medicine are on STIs, sexually transmitted infections, and HIV. And when I say latest, by the way, we're recording this in May 2026. So I'm referring specifically to the April and May issues of 2026, in case anybody who's watching this would like to go and read more about the topics we'll discuss or anything else to do with STIs and HIV. They're all in the Medicine Journal in those particular issues. And so we'll try and cover a couple of things in the course of this video cast. We might also touch on things that are not necessarily in the actual issues. But anyway, so STIs, still an important issue, would you say, Tristan?
Absolutely. Thank you very much for having me. I'm Tristan Barber. I'm a consultant in HIV medicine and sexual health working at the Royal Free Hospital in London. I'm also the current chair of the British HIV Association. I'm really excited about this collection of articles. Albert, thank you for having us here to talk about it. I think when I think about STIs and HIV, I think the compelling thing for anyone watching this is I think we're really at a point now where we need to make sure that STIs and HIV are on everyone's radar. We have very good specialist services in the UK engaged in STI treatment and prevention, HIV treatment and prevention. We have some of the best HIV outcomes in the world because of the integrated system we have with the National Health Service. But we kind of have a final mile problem in that there's only so much we can do in specialist services if STIs, HIV and bloodborne viruses aren't on everyone else's radar as well. And we've seen an increase in some sexually transmitted infections around the world and in the UK. We particularly see an epidemic of syphilis, an increase in syphilis numbers affecting people who may never have thought that syphilis was something that could affect them. We've seen cases of congenital syphilis as well, which really shouldn't be happening in 2026. And we have a new HIV action plan in England, at least, and we also have similar action plans in other nations of the UK looking to try and end new HIV transmissions by 2030. This was launched on World AIDS Day back in December 2025. And it means that I think every healthcare professional needs to be considering whether or not the person in front of them knows their HIV status. They don't need to take a complex sexual history. They just need to know that HIV is treatable. You can have a normal life expectancy and offer people testing where and when they see them.
So that's obviously important, an important thing to bear in mind, that once HIV was a killer and now you can have a normal life expectancy. Thanks, Tristan. Karen, turning to you, and please do tell us a bit about yourself and your views on this, please.
Hi, I'm Karen Rogstad. I'm a consultant in HIV and sexual health who actually is towards the end of her career now. But when I came into this area, HIV was universally killed all my patients. And, to now be at the stage where, we can prevent people getting it, we can treat them so nobody should be dying from it. And it's been an amazing development. But for that to happen, you've got to be able to have access to care. You've got to get rid of stigma so people feel happy about coming and that people get tested. And you have to have access for high quality services in the UK and worldwide. The other huge development since I came to this specialty has been that tests have gone from being very complex and needing to be performed by specialists like Tristan and myself to a situation where patients can take their own tests. They can order them by post. They can take their own tests, and in some cases, they can get treatments delivered to them. However, there's still this requirement for specialist services. New STIs are evolving all the time. People have other burdens of mental health issues, drug issues, and complex psychological issues. So it's really important that, as Tristan said, we keep this at the forefront of people's minds and that services are maintained.
Indeed. And you mentioned the stigma, and there is still a stigma attached to HIV, isn't there? Maybe less than back in the 1980s or whatever, but it's still there.
Yeah, and it's particularly worse in some communities. So we know with the HIV that the numbers are still increasing in men in the UK, and men who have sex with men from certain minority groups. I don't know if Tristan would want to say more about that.
Mm-hmm. Yeah, Tristan. Yeah, go ahead.
Absolutely. I mean, I agree, Karen. We've seen a reduction in HIV in mainly white gay and bisexual men who have sex with men, particularly in metropolitan areas, people with higher health literacy, people with more agency, people from better socioeconomic groups who can access prevention technologies like pre-exposure prophylaxis, can access some of the big central urban sexual health and HIV clinics, whereas we've seen rates maintained or even going up slightly in particularly Black African MSM and also in some heterosexual groups as well. I think particularly in heterosexual groups, people may never have seen HIV prevention or testing messaging as being directed at them. We now have an ED opt-out testing program in England, where in high prevalence areas in particular, people who attend accident and emergency departments and have a blood test are tested for HIV, hepatitis B and hepatitis C. And the people we see diagnosed through that program often have ideas about HIV that are 20 or 30 years out of date. So I think that's been a failure on our behalf as specialist services to not make sure that everyone understands the benefits of knowing their HIV status in particular. I mean, all of these viruses are treatable. And I think also promoting the message that if you are living with HIV, you're diagnosed at an early stage, but on treatment, you can have a normal life expectancy. But also, if you achieve an undetectable HIV viral load on treatment, you cannot transmit your virus sexually. This is a statement known as U equals U, or undetectable equals untransmissible. We also know that stigma persists in healthcare settings. So I think we've been guilty of not spreading the message about the benefits of testing and HIV treatment with some of our healthcare colleagues. And that can limit people's offer of testing, when in actual fact, this is a treatable virus, very manageable, just an infection like any other infection in terms of something that can be picked up, diagnosed and managed. And we need to get rid of that HIV stigma that prevents people offering the right advice and testing.
So you make the point. Sorry, Karen, carry on.
Sorry, I was just, if I can just interject, the other bit is there's still stigma with other STIs as well.
That's brilliant.
And say, for example, syphilis, which is having a dramatic increase, and we're starting to see cases of congenital syphilis. People aren't being tested for that outside sexual health clinics or antenatal clinics, or people are assuming nice people don't get syphilis. Anybody can get syphilis, and seeing congenital syphilis again in this country is a huge tragedy.
So I think the point that you're both making, if I understand correctly, is that if we can destigmatize not just HIV, but all STIs, if we can destigmatize them and make testing more widely available and make people more willing to undergo that testing, a lot of them are entirely preventable or more easily treatable. Is that right?
Yes, syphilis is treated with antibiotics. And of course, you can treat partners and then prevent onward transmission, because it's not actually that infectious apart from a mother to a baby. So you could make great inroads, but you have to be testing. And I think the medical profession and nursing profession are some of the worst for not actually thinking of syphilis and for not testing for it.
No, thank you. Tristan, one of the things that I think you mentioned earlier on is about prophylaxis, prevention. And there are ways, increasing ways now, that people can protect themselves. And do you want to maybe just say a word or two about that?
Yes, so we have ways that people can reduce their risk of bacterial STIs and also of HIV. So with regard to HIV, we try and use combination prevention approaches. So of course, regular testing, condoms where people want to use condoms. But in addition, we have pharmacological pre-exposure prophylaxis for HIV. The most common way of accessing this prophylaxis, or PrEP as we call it for short, is oral pre-exposure prophylaxis, usually with a combination of 2 drugs in 1 pill that can be taken every day. If sex is predictable for some people, it can be taken as event-based PrEP, so it can be taken around the time of sex. And you need some specialist support and advice, really, if you're going to take PrEP that way. But daily oral PrEP is very, very effective. In studies, at least 96% effective at reducing HIV acquisition. But actually, when you look at the drug levels in people taking PrEP, if you're taking your PrEP properly, it's probably approaching 100% effective.
Okay.
There is also now injectable PrEP, which can be given once every 2 months. It's a little bit more expensive, so we have criteria around who can access that. And with regard to bacterial STIs, people can take doxycycline as post-exposure prophylaxis, which reduces the risk particularly of syphilis and of chlamydia. It probably doesn't have so much of an effect on gonorrhea, but can be effective for people, particularly those with lots of sexual partners.
What about AIDS-related illness? I think that as a generalist, my impression is that the incidence and prevalence of that has gone down quite a lot over the years, but it's still there. Am I right in that assumption, or is it still a big problem?
Oh, I mean, compared with how it used to be, we see and should see very little AIDS-related illness, although we still are seeing it, and that's a factor of late diagnosis where people don't come forward for testing, or people don't think of testing patients who might be at risk. However, we're seeing more complications in our HIV patients that may not be related to advanced stage HIV. We are seeing quite high levels of cancer related to anal cancer, which is a factor from the HPV virus.
Thank you. Yes. Tristan?
So I think it's true. We are still seeing AIDS-related problems. And as Karen has indicated, one of the problems here is with late diagnosis. So I think it's a travesty that in 2026, I'm in London and I still see people diagnosed with late advanced HIV and AIDS-related complications. Of course, we still see some people who are diagnosed with HIV who struggle with taking their treatment, who may end up with an AIDS-defining illness. But I think what's inequitable is that the people I'm often seeing with AIDS-defining conditions are the people that fall into what I would call non-traditional historical risk groups. And so these are people that are not being offered testing where they're approaching healthcare professionals for medical care. And often when we look back, we see that they've engaged with outpatient services, with their GP multiple times in the year or two prior to diagnosis, and no one's offered them an HIV test. And that means that we see, for want of a better word, I hate the phrase middle-aged, but middle-aged heterosexuals admitted with AIDS-defining complications because no one's ever thought HIV is something that they should be tested for. And this is why I say we're in this kind of final mile problem, where as specialists, there's a limit to what we can do, because if people come to our clinics, we will test them for HIV. But what we really need is our generalist colleagues to have HIV on their radar and offer it as a standard test without judgment, without the need for special questioning or taking a sexual history, just as a treatable virus that is best picked up early and seeing it as something that's standard as part of routine holistic healthcare.
And I guess that's one of the reasons that we publish these 2 issues in medicine, is to actually make the generalists more aware about these issues and think about them. It shouldn't just be a specialist problem that people like you two are seeing, although obviously you have an important place, but the generalist needs to be aware of these issues. And maybe, Karen, if I could come back to you, one of the issues, and it's kind of related to what we were talking about, is especially around young people, but safeguarding in the context of consultations around sexual health. It's a tricky area, isn't it? And how do you navigate that?
I think you've got, in every consultation, you should always be thinking safeguarding. Whether it's in a sexual health clinic where we do have lots of safeguarding issues, But in any other situation, if you've got a person with learning difficulties attending one of your services, they could be at risk of sexual abuse, exploitation. Anybody dealing with, teenagers, 16 to 18, there could be issues. And we really think about it with every case. And for every under 18-year-old, we perform a set of screening questions, which is very simple. It's on the Bash&Brook website, that are just raise key indicators about whether somebody could be at risk of sexual violence, sexual abuse or exploitation, or domestic violence as well.
Yeah, sure. And Tristan, do you see it? Do you see this as an issue in your clinics as well?
Yeah, tremendously important. And, I think we're very good in HIV and sexual health services at following up on safeguarding issues. I always think the key thing here is about working as a team, isn't it? For too long, we've often thought of our sexual health services, sometimes our HIV clinics, as being tucked away in a porter cabin at the back of the hospital, if you're lucky, in the car park. What it really means is that people that, they don't need to be specialists at doing safeguarding assessments, but if they detect that there is an issue, pick up the phone and call us, because we're really happy to get involved and to help. And I think Karen's also indicated a really other important risk group actually for HIV that's missed. We've seen an uptick in HIV diagnoses in young people who, again, may not perceive themselves as being at risk. I've had people who are newly diagnosed who are young who said, "Oh, I thought that only happened to older people," or "I thought it was in the past." So, any concern, anything that flags, just pick up a phone, call us, or send us an email. And, we're always happy to get people engaged into sexual health or HIV services.
Thank you very much, Tristan and Karen. I think it's been a fascinating discussion, brought up some interesting and important issues that I think are of relevance to generalists as well. So once again, thank you both very much indeed for joining me today.